Thank you all for being here. I'm Bonnie Mohan. I'm the Executive Director of the Health and Housing Consortium. We are hosting this convening over 2 days to share information about medical respite. I really want to thank our planning committee. So we've been organizing this event for probably close to 5 months now. And in doing so, we really wanted to make sure that we were addressing the needs of people in different stakeholders who might be interested and involved in respite at in different capacities. So we brought together this planning committee representing current respite providers, community organizations that are interested in medical respite, different hospitals, some that are currently funding respite, some that are curious about it, and same thing with managed care organizations, some that are currently involved in respite and some that are just interested. So through the expertise of this group, we've been able to put this event together, and we're really excited to have you all here. So here's the agenda for the event. We just wrapped up earlier this morning a Medical Respite 101 session. Hopefully many of you were able to attend that session. If you weren't, we did record it, and that recording will be available later. It's a good primer on medical respite from a national context down to how it's operating currently in New York City. This is, of course, our session on the Medicaid pilot for medical respite that will be launched later this year through the State Department of Health, where we're so excited to be able to learn more about that. And then tomorrow is really our opportunity to get into the weeds, to get into the details of what respite looks like. So we have different breakout sessions. Our morning session, people will be broken up by stakeholder group. So we have a group for hospitals and healthcare providers, for respite providers and those interested in starting a respite program, for health insurers and managed care organizations, and finally for respite participants themselves, because we really want to make sure that we hear from them about their experience and recommendations as we plan for more medical respite. And then finally, we'll close the day with a short networking session so you can meet people, exchange information, and start putting some of this information into action. We are really excited to have, first, before we get into the details of the Medicaid pilot program, to have Deputy Mayor Ann Williams-Isom here, who's the Deputy Mayor of Health and Human Services. She oversees the city's health and social services agencies, including New York City Health and Hospitals and the Department of Social Services. Prior to this appointment, she served for more than 25 years as a nonprofit executive, attorney, and educational leader with a passion for family well-being and community development. As former chair of Fordham University's Graduate School of Social Service, Ms. Williams-Isom led interdisciplinary programs and policy research that improved services to underserved families of color using a social justice lens. Additionally, Ms. Williams-Isom served as Deputy New York City Commissioner for the Division of Community and Government Affairs, where she instituted several innovations, including frontline staff trainings to improve investigations of child abuse and neglect. A native New Yorker, Ms. Williams-Isom holds a bachelor's degree in political science and psychology from Fordham University. I also have a degree in political science from Fordham University and a law degree from Columbia Law School. So we are so excited to have Deputy Mayor here with us today, and I will welcome her for some remarks.
Hi, Bonnie, can you hear me? Okay, great. I just wanted to make sure you could hear me. I don't want to get cut off because I am on the move, literally. I just wanted to thank you all and to say good luck today in this very important work that you're doing. As Bonnie said, my background is mostly in human services. And so when I see models like this that are really geared towards the realization that people's needs are very unique and that we need to give people what they need when they need it, it's why I'm so excited about this medical respite program. So I'm honored to be here at this gathering of the Health and Housing Consortium. And I want to thank each one of you for this good work and all the partners that are city, state, and healthcare partners that are here today. Health and Hospitals, of course, DOH, NYU, Community Life, Montefiore, ICL, CAMPA, Brisboro, NYLAG, Metro Plus, Health First, and Empire Blue Cross. You've heard an excellent overview this morning from some of the best people in the field. And of course, I'm especially excited about Marjorie Ellis from H&H. I heard her passionate presentation and briefing earlier in the week, and it just blew me away. Not because I'm surprised, but I'm just so happy to be back in government with people that really are committed to getting some of the most vulnerable New Yorkers help. And about vulnerability, being homeless is vulnerable, but on top of that, to have a condition and to be able to have this medical respite will be so, so important. That's a critical solution. That's a service system for people experiencing homelessness and expands the tools that we have in our toolkit. I'm really excited when I think about the fact that Mayor Adams is really pushing all of us to think innovatively about solutions. And I just think I love the concept that housing is healthcare. And how can we think about those two things together? And how can respite be a very, very important part of a continuum that's needed for some of our most vulnerable New Yorker? I've been excited to hear about the work that H&H is doing. They never cease to amaze me under the great Mitch Katz. And so I'm glad that you heard some of that, and we'll get some ideas as we move forward. Your next set of speakers is going to give you the technical details about medical respite so that you can see and understand more of the realities of the program. I just wanted to be here to encourage you, to say how I'm so excited about this work. I won't be able to say for the full day, but I want to come back. I want to see more. I want to learn more. And I wanted you to know how personally supportive I am as the deputy mayor, as a New Yorker, as a partner in caring so much for vulnerable population. We all know New York is going through such a difficult time. And in order for us to get to where we need, have to get on the other side of recovery. And so that means that we need to pay attention to the needs of all New Yorkers, especially our homeless brothers and sisters. So thank you again. Good luck on your conference today. And I will hand it back to Bonnie for your next panel. Thank you again for all that you're doing for New Yorkers. Thank you.
Thank you so much, Deputy Mayor. We're so glad to have you here and have the support of you and this administration. And medical respite has come such a long way in the past few years, and so we're really grateful to have your support and enthusiasm for a program that really just makes a whole lot of sense. I'm so pleased now to introduce a long partner in this work, Julie Brandfield, who's the Associate Director of Legal Health, a division of the New York Legal Assistance Group. Legal Health is the nation's largest medical legal partnership, complementing healthcare with legal care at 36 hospitals across New York City, Westchester, and Long Island. Julie is responsible for establishing new clinics, supervising staff attorneys, policy initiatives, and she oversees Legal Health's training curriculum for healthcare providers. Julie has been at the forefront of Legal Health's policy initiatives to establish medical respite for the medically homeless and immigrant access to Medicaid. Julie has over 30 years of legal experience after graduating from Fordham University Law School. And I just want to say on a personal note, NILAG has been such an important partner to the Health and Housing Consortium. They've done a lot of trainings for us and will continue to. And really, for the past several years, NILAG has been an important partner in advancing medical respite and Julie in particular. So we're really excited to have Julie as our moderator for this session. And I will hand it over to her to introduce our speaker, Emily Engel.
Thank you, Bonnie. Really kind words. It's definitely been a long haul getting to this point, and Deputy Mayor's enthusiasm was just, so wonderful to have her here and hear the enthusiasm behind medical respite. I still remember some of Legal Health's first clients back in 2014-15. These were clients that really prompted us to get into advocating for medical respite in New York State. As a medical legal partnership, we had partnered with 30 hospitals at that time, and we had patients who could benefit from medical respite. And if they were hospitalized at Montefiore, who had the wonderful program that we learned about this morning with Communal Life, they could get a respite bed and continue their chemotherapy. But if they were a very similar patient, homeless patient at a different hospital, they had absolutely no access to medical respite, and they might stay in the hospital for months longer, and sometimes had to be on lower doses of chemotherapy because they were hospitalized and couldn't be too immune compromised and susceptible to hospital-borne infections. So it was those types of cases that led us to form the Coalition for Housing and Health and get involved with so many of you who've been on the ground since the beginning. 2018-19, we held 3 forums. Many of you participated in those. We published a report in 2019 and advocated for legislation that we finally have today. So needless to say, I'm really incredibly excited to be here today and to introduce you to our next speaker, Emily Engel. Emily is the director of the Bureau of Social Care and Community within the Office of Health Insurance Programs at New York State Department of Health. Emily's work is focused on creating better health outcomes for vulnerable Medicaid members through integrating social determinants of health and CBOs into the healthcare system. She has provided guidance to the Medicaid redesign team, supportive housing initiative, which has invested over $800 million into housing for high-need Medicaid members. So it's really wonderful to have Emily here today. I'm going to turn it over to Emily, who has a presentation, and then we'll have an opportunity for questions from you all.
Hi, everyone. I'm so happy to be here today and talk about this. This pilot has been a long time in the making. And finally, we're really close to being able to release the pilot. So this event was really great timing with what we're trying to do on the state level. Dive right in. I'm going to talk about, I really, after that 101 today, I do not have to do an overview of medical respite. That was really great hearing from everyone this morning, and it was much more detailed than I could ever do. But I will talk about, what our vision at the Department of Health is for these medical respite pilots and beyond, and the role of Medicaid managed care organizations and hospitals with medical respite, and give a timeline, updated timeline of our pilot. So we can probably go to the next slide. Like this was all covered this morning in great depth. We have the same definition of medical respite, that it provides alternative setting to the street or unstable housing, which individuals can recover and heal, reduces preventable readmissions and unnecessary emergency department visits, and offers a pathway to supportive housing as well as other coordination of important services. So this pilot is to launch this year. We are really looking to develop a proof of concept for ongoing inclusion of medical respite in the Medicaid program. There's been a lot of research on medical respite. We know that this is an effective service. We know that it reduces the readmissions of inpatient and ED visits, and so we want to test the delivery of medical respite services through the Medicaid program. We want to invest in capacity building for medical respite programs. We want to lay the foundation for the expansion of medical respite programs across the state, especially as we are about to release our 1115 waiver application for public comment and submission to CMS. I will say medical respite is included in there, so this is really building up and laying the groundwork for future inclusion in the Medicaid program. Under the pilot, we will award $50,000 to up to 8 medical respite sites. We will develop a mechanism for Medicaid reimbursement of medical respite services, probably through managed care organizations that want to participate in the pilot. And we will provide ongoing technical assistance for medical pilot programs before and after the launch, and refine the medical respite program guidance based on the experience. We'll have guidance, that really directs how these medical respite programs will function with the payment mechanism and whatnot. And we want to learn from this pilot, so like I said, it can be expanded in the future. So right now, we had to limit it to 8 people. This was through the MRT2 initiative. which looks at cost savings ideas to include in the Medicaid program. And so under MRT2, we were limited to 8 areas. We looked at data of homelessness as well as high inpatient utilization related, that homeless individuals with high inpatient utilization. And we targeted that to the Capital Region, Finger Lakes, New York City, Long Island, and the Western New York region. And so these pilots, again, will be designated to those regions at this time. And our hope is to obviously expand this in the future with more, once we conduct the pilot. The next slide. So I mentioned that this is under an MRT2 initiative. And so this really has 3 components to it. The first is creating regulations and a certification for medical respite programs. Currently, there is no certification. Other states have like a license or certification that defines what a medical respite is. Right now in the state, we just have a social respite program, which doesn't address or allow for any medical care. It's just connection to the social services. And so by creating a medical respite program and having regulations, we're allowing medical respites to enter into the Medicaid space. And so the second component is creating a mechanism for the pilot to pay per diem for medical respite. So we're looking at, how to have a, per day rate that we can pay for medical respite through probably managed care organizations. And the third component is capacity building for the medical respites that apply for the certification, giving them some grant dollars to allow them to, apply for the certification, also any staffing that they need, or program changes. That money would just really be a support for the pilot. And then, this again is all towards, being able to further expand medical respite capacity and services in the future after the pilot. So through the launch, we will develop and test financing mechanisms for medical respite services delivered through Medicaid managed care programs. We'll invest in the capacity building for medical respite programs. And, again, the regulations will be kind of just a standard of existing programs. We really didn't want to, rewrite or undo any of the good work that has happened. So we've really thought of what's existing and how can we complement what is existing currently in the state, and just allow it to be a certified process and get grant dollars and payment through Medicaid. Go to the next slide. So the minimum qualifications for the pilot program participants must be a non-for-profit organization eligible to do business in New York State, commit to being certified by the Department of Health as a medical respite provider, have 3 or more years of experience in providing care coordination and supportive services to homeless and other vulnerable populations, not to appear on the New York State Office of Medicaid Inspector General Medicaid fraud list exclusion, no record of poor performance, not appear in internal review service charities, and not on any other applicable federal or New York State exclusion lists. So those medical respite facilities that want to apply, or if you're not a medical respite facility but you're interested in becoming one, these are the kind of preliminary criteria that will be needed to apply for the certification. So what are the expectations? I think there's a lot of nervousness around this, especially when you start talking about regulations and certifications, and what does that mean for the medical respite program? So in general, entities can apply for the medical respite certification as long as they meet that past slide that we just talked about. They can contract with Medicaid managed care organizations for the provision of medical respite and comply with the New York statute regulations and program guidance. Again, that regulations and guidance, it's not outside of the box of what is currently existing. It was really, we thought of, how much work has already gone into the existing contracts between plans and hospitals and medical respite programs, and we didn't want to undo that work. We just wanted to give a mechanism for additional payment and also inclusion in the Medicaid program. So services will provide a temporary room and board, including meals and 24/7 access to bed, develop and monitor medical respite service plans, perform care coordination services and daily wellness checks, plan discharge with the consideration of housing options, healthcare provider referrals, and supportive services. Again, as we know from the 101, these are services that are already conducted through medical respite programs. Facility and staffing, ensure the staffing allows for 24/7 on-site personnel with first aid and basic life support training, and call coverage by a licensed healthcare provider, an administrator responsible for operating the program, personnel to perform care coordination functions, and ensure the facility, and this is where the regulations come into effect, that the facility is in good state of repair and sanitation, and it's sufficient to support an individual's rest and recuperation. Other components really is just to implement a quality improvement program to evaluate the effectiveness and areas of concern for a program. That's just part, again, of a regulation if there's something that is, of concern. Adopt and publicly post programmatic rules for medical respite recipients, and collect and maintain information, records, and reports required by Department of Health, such as who is being served and for how long. So as I mentioned, there's kind of two buckets of funds that we're looking at implementing with this pilot. The first is the program, the pilot funds, which would go directly to the medical respite providers who apply for the certification. And that would be for building site capacity, hiring or contracting with staff, meeting credentialing standards, including the physical space requirements, increasing program capacity to serve more individuals, developing capabilities to enable contracting with Medicaid managed care organizations, such as resources to execute contracts with Medicaid managed care organizations, process for billing and invoicing, if that's going to be different, and data sharing system and capabilities, and obviously, staff training and technical assistance for staff. So that would be money that's directly given to the medical respites for them to carry out those functions. And then there's a service reimbursement piece where for the actual individuals being referred by a Medicaid managed care organization, or if they're partnered with the hospital, by the hospital. And so that DOH will have a per diem amount where it is a set amount and would go to the medical respite for the service of for the medical respite service. The Medicaid managed care organizations, like I said, will pay the medical respite providers the per diem rate, and DOH will provide technical assistance to all parties involved in the pilot. And I should say, a question that comes up a lot is, what about existing contracts, right? Like, does this mean you can't have existing outside grant funding? And this absolutely does not preclude outside grant funding. This is just supposed to be another revenue source in order to grow the capacity of medical respite programs. And so the role of Medicaid managed care organizations and hospitals is really important in this pilot. So we envision that the plans will offer medical respite to qualifying members. Again, we're working on the mechanism for payment at this time. Interested plans will be able to voluntarily opt in to participating in the pilot. Offering medical respite, as I loved that slide in the 101. It reduces your per capita costs. It improves quality outcomes and better serves members and communities. The research is all out there proving this is a very evidence-based intervention. And plan participation will really be essential. Like I mentioned, by contracting with medical respite providers, plans can help expand medical respites across the state, and they're really going to be an important part of the pilot. And hospitals as well, obviously, have a huge role as well. New York State hospitals routinely face non-medical necessary discharge delays due to lack of safe discharge, or they have patients with complex needs. And so, when there's limited bed availability, others who need assistance and can't get into the bed because the individual who doesn't necessarily need a hospital stay, they don't need the hospital level of care, can't be discharged safely to the community. And so this pilot is really focused on helping hospitals, and we envision them working really closely with Medicaid managed care organizations for referrals and discharge. And overall, providing a safe pathway to the medical respite, and the medical respite helping with that stable housing. And I kind of covered this in my last slide, but hospitals will be essential in identifying individuals for the pilot. Individuals will be eligible for admission under this pilot if they have a qualifying health condition that no longer requires hospital inpatient observation unit or emergency room level of care, are homeless or at risk of homeless, 18 years or older, able to perform activities of daily living with no minimal assistance, are self-directing and able with direction to take sufficient action to ensure self-preservation in emergency, and don't pose a risk to themselves or others. And this criteria, you'll notice, it matches a lot of what was talked about in the 101. We didn't try to recreate the wheel here, just use what the existing structure is in New York State. So hospitals, in our pilot, we envision the hospitals providing medical respite programs with the documentation like they do now. They will then make sure the the medical respite will then perform a person-centered assessment to determine clinical needs or other supportive services, develop care plans in consultation with the managed care organization or health home. Upon admitting individuals to a medical respite, the medical respite programs will offer care coordination, such as scheduling healthcare appointments or arranging transportation, all which is currently done, provide or arrange needed primary or specialty care or other clinical services, identify housing options, facilitate housing placement, and engage in the planning discharge to permanent housing if available, or transitional housing, really appropriate housing. So the timeline, as I mentioned, this is an MRT2 pilot. We are hoping that we can release the initial call for funding for individuals in late June. We're calling it a solicitation of interest. for medical respite providers that are interested in applying for the certification, or will be applying for the certification, I should say. Our regulations, we are expecting them to come out either later this month or in May. During that time, there will be a public comment period, and then we have time to change the regulations based on those public comments. And then after that window is closed, the regulations will go into effect. So we're really hoping that we can get those out, late, again, like I said, later this month, or sooner than later than in next month, because it's really an important part of the whole program, and we can't move forward with the certification or the solicitation of interest till we have those released. So it's been an interesting process. And education outreach, again, we're going to line that up with the SOI to make sure that we have, technical assistance. We'll be hosting a series of webinars related to the SOI for medical respite providers, the certification, talking to managed care organizations and hospitals, just to make sure that everyone has a clear understanding of the pilot, and help with any hiccups along the way. So I know that was a lot of information. I do have my email here, but happy to answer any questions that might be in the chat box.
Great. Thank you very much, Emily. Those wonderful slides, very clear, a great and clear presentation. So thank you very much. We have like 30 minutes or more for questions, so this is excellent. I wanted to start off with a couple questions. I was really struck this morning in the first session by Raimundo's comments and presentation, and his experience in respite. And particularly what stood out for me was the fact that nobody had told him about it. They were trying to figure out a discharge plan. And another patient mentioned respite to him, which just was like, wow. And then he mentioned it to the healthcare provider, to the medical team, and went pretty smoothly after that. And I know that you said that there's a, part of the requirements are education, seem to be focused on the respite side. And I'm wondering if there's any criteria for education at the hospital side, who's going to be partnering with the respite providers and the MCOs, because that's the key staff to educate, so that they know how to identify the patients. And hospitals are already at their bandwidth, and I'm just wondering if you could speak a little bit to that, because that's a key piece. And I myself have had clients where we've been working on client matters, and we'd be like, oh, this person would be a good candidate for respite, and then I tell the social workers, and they move forward with it.
No, that's a really good point. And I think that technical assistance piece with the participating managed care organizations and hospitals is going to be really important, especially about the eligibility criteria and looking at that homeless data, right? If you have someone who's reoccurring in and out of the hospital, and you see they just keep getting discharged to the shelter, how to flag them and make sure that they're connected appropriately to a medical respite. I think that is going to be really important, and something we should definitely work into the technical assistance.
Great. Another question that has come up frequently in the years we've been discussing this is, when we think about pathways to housing and eligibility for various supports, the duration of somebody's homelessness is a key factor, their homeless chronicity. And I'm wondering, if someone is placed in medical respite, will their stay be counted toward their homelessness chronicity?
We are really working on that piece now to make sure that the medical respite isn't considered housed status, especially in New York City. We want it to count towards homelessness. So that's a really important piece, and we're working on that now.
Great, that's fantastic to hear. And it doesn't seem so. I mean, I think you touched upon this a little bit, but I just want to make sure that you clarify in the Medicaid pilots, there are no limits on where people can be referred to. It's not just limited to hospital referrals. Is that correct?
No,
Could
as
they be
long as
from
they meet
community?
that eligibility criteria, yeah.
Okay, great, great. Great. So let me look at some of the questions in the chat, and we'll get to those. Does an organization seeking to apply for a pilot already have to be billing Medicaid or managed care organizations?
No, no, they don't have to be already billing. You know, it's going to be open to organizations that are currently medical respites or organizations that you know, wish to become a medical respite and are able to you know, secure a site and you know, start a medical respite. So we'll be targeting 2 groups there. But if someone is not a Medicaid biller, they wouldn't be excluded from the pilot.
Okay, thank you. Another question is, what type of licensed healthcare providers qualify for the on-call requirement?
That's going to be fleshed out in the regulations. I think during the public comment period, we'll make sure that, you know, this is that they're circulated, and we can make sure that it's in line with you know, what everyone feels is appropriate. But right now we just have, you know, the broad, you know, someone on call licensed healthcare provider, but we're gonna have to flush a lot of that out in regulations and rely on public comment.
Okay, great. Another question is whether there is a limit to the number of days that a patient will be eligible for the reimbursement through the managed care organization.
So typically, with this pilot, we were looking at the 30 to 60-day window. Imagine if a managed care organization feels that someone needs a longer stay, that they would be able to extend that.
And that will be like discretionary and sort of just
right. Yeah, between the medical respite provider and the managed care organization.
So they'll just make a case for that extension. Okay, great.
Wanted to leave things flexible because every case is different. So flexibility, I think, is key. And like I said, we're learning from this pilot so that we can, you know, expand in the future. So, you know, leaving things a little bit flexible and having guidance that we're able to revise and change, I think is an important piece.
Yeah, and I imagine we might find that lengths of stay may differ depending on the location across New York State, and what the housing resources are available to patients and the backlog and applying for, you know, supportive housing in one county. That process might be faster than it is, say, in New York City.
Absolutely.
Great. Will Respite be able to take a client with a primary diagnosis of mental health conditions?
I don't think there's any limitation on that. It really, as long as they are, you know, meeting that those points that I had earlier in the slide deck. I don't think there's any exclusion as long as you know, they need the medical respite service.
Okay. And then just on the scope of the pilot, there's a question posted about how many programs. Is it 8 pilots throughout New York State or in New York City?
Throughout the state.
Okay.
Yep. In those regions, I had that map. It was Western New York, Capital Region, New York City, Long Island, and I'm forgetting.
Yeah, Westchester, I think it was. I can't remember either, but I do remember that you had the
Finger Lakes.
Finger Lakes. Okay. What about self-referrals? Will they be allowed or encouraged?
I don't think self-referrals would be under this pilot. Again, don't forget there's other grant funding through medical respites, and we're not taking away that or saying that's not allowed. But for this, it has to flow through the Medicaid managed care organization, the hospital, in the medical respite program. So I don't think a self-referral would be appropriate in this case.
Right. And it may even, just thinking about it, may be difficult to have sort of all that upfront information that's required coming from the medical providers. And so I can see that being a challenge. When a hospital discharging physician or social worker doesn't know about medical respite, how can a patient help them, who to send them to? That's sort of like my first question, I think.
Yeah.
Yeah, just education being very, very important. Are providers reimbursed a flat rate per patient, or is it a per service during their stay, i.e. care coordination services, housing connection, etc.?
The way we're currently looking at the payment is a per diem per day. So it wouldn't be like a flat rate. It would just be a per day cost.
Okay, great. And will those costs differ? I mean, will those rates differ based on sort of geographical costs of services?
No,
or?
at this time we just have kind of one rate that we're looking at, and again we're looking at the mechanism for how to flow that through the managed care organization.
I think I know. I'll ask the question. I think I know the answer. Does medical respite service only pertain to New York City Health and Hospitals? I work with New York Presbyterian, which is not part of H&H. Can any hospital make a referral?
Yes, the idea would be, multiple managed care organizations participating as well as hospitals. So it wouldn't just be one hospital or one organization.
Right. So I can imagine that, let's just say Empire Blue Cross, expands. They have, they're one of the pilots, or they're working under one of the pilots. They have members at 5 different hospitals that could potentially be referring into respite and have this reimbursement.
Exactly. Yeah.
And similarly, like H&H, if they were participating and had members going, or patients who were members of a managed care company, they could be sent to respite and have Medicaid reimbursement. But then they could also have an undocumented patient who has no health insurance, and because they have other additional contracts, they might be able to send those patients to a medical respite bed as well. But if New York Presbyterian didn't contract to have additional medical respite beds, they may have some patients who could go and some patients who couldn't go because of their insurance status.
Yeah, and existing contracts stand, existing flows. So someone who's undocumented, not enrolled in Medicaid, can definitely go through the other grant funds. But the payments flowed through the managed care organizations could touch multiple hospitals, and within 1 or 2 medical respites. Yeah.
Thank you. Can you clearly describe the amount and scope of actual clinical medical care that will be provided to a respite client who needs it?
Again, that's in the regulations, and it's really the provision of or arrangement of the services. This isn't hospital level of care. We are not trying to change the level of care that medical respites provide. So it's very light touch. We're not expecting, full medical services to be provided or anything like that. That one slide that has the expectations of the pilot kind of defines the broader goals within the facility and staffing. But again, nothing that is outside of the scope of a respite.
We know the cost for medical care is running away. I think most people will agree that Medicare for all is the way to go. You've mentioned Medicare, Medicaid managed care. We know that managed care allows corporate involvement into our care. Corporate involvement have been encouraged, but it adds costs to an already large budget. Why involve them and not pay through Medicare and Medicaid programs? I think it's basically why not pay? Why do it through managed care versus straight Medicaid and Medicare?
So because the largest percent of Medicaid members is under managed care organizations anyway. And as far as for this pilot and our payment flow, we're able to work through managed care organizations and their membership. So that's kind of versus Medicare is kind of getting away from our scope and where we're able to pay. So this is focused on Medicaid and managed care, just because that's the scope of our pilot. And in the future, when we look at 1115 funding, again, that's looking at value-based payment arrangements between managed care organizations and value-based payment contractors, such as hospitals or independent practice associations. And then it's again capturing the same audience. So this pilot is really to tee up to future capacity and expansion. And so with managed care directing payment now, we'll be able to kind of expand that and grow it in the future with the 1115 waiver, when that's approved by CMS.
Thank you. To follow up a little bit back to the prior question on sort of the one flat per diem rate, if part of that, if this rate includes room and board, they're going to be rent costs. How can a program in Western New York be paid the same rate as a program in New York City? The concern is that is going to, because of just the higher physical costs, it's going to pull away from having the robust services. There'll be less money for robust services in the respite program.
No, and I know for the cost, we were looking at the New York City rates when we're looking at the medical respite rate, and like I said, nothing has been set yet. So, we're happy to look at upstate versus downstate, but I know when we're looking at the initial rates, we were looking at downstate costs, and I definitely appreciate the difference in Western New York versus New York City, and especially the rent costs and how burdensome that can be for different programs. So it's definitely something to keep in mind.
Okay, thank you. Any speculation on the difference in reimbursement rates between New York State medical respite and social respite?
That means
Is there current? I'm not aware. Is there currently a reimbursement rate for social respite?
no.
Okay.
I think it's just the individual contracts through that are already standing that aren't related to this pilot.
Okay.
And I think my understanding is each plan and hospital works out their own rate with the medical respite provider.
Okay, thank you. What reception have you gotten from the managed care organizations to reimburse for this service?
We held a initial webinar a few months back just to kind of let them know that this would be coming down the pipeline. It's really well received, so we're optimistic that there will be a lot of participation in it. Now that we're getting closer to the regulations being released, now's the time to kind of for us to follow up and share those partnerships. But we have to figure out the payment mechanism and kind of loop them in more now that we're further down the line in the implementation of the pilot.
Great. I'm curious how many different organizations attended the event that you had. And were they from across the state?
Testing my memory, it was across the state.
But
I'm
it,
not-
it
I'm
felt,
not sure.
did
I
it
know
feel
it was a good holding.
representative, or was it, you know?
I know all the main managed care organizations were there.
Okay, great.
Yeah.
Super.
Testing my memory.
Okay, sorry. Under the Medicaid pilots, will referrals need to come from hospitals only, or could someone be referred by their MCO or provider in the community? I think you've already said that they could be referred from their MCO, but the question of a provider in the community, I mean, that's an interesting one, whether a, standalone health
Yeah, they would
doctor.
have to meet that criteria. So again, I'm wondering if the regulations might address that or not. So we'd have to take a peek at that, but they would have to meet that ED and patient criteria versus just being referred from the community or self-referral.
Is the certification with Department of Health required for all respite providers, or only those applying to operate through the Medicaid pilot program?
So it will be required for anyone who wants to operate through the Medicaid program, that are interested in the pilot funds and the reimbursement through Medicaid.
So,
so if there's a medical respite currently that's providing, the social respite, and they don't want to, participate, they don't have to. There's no, it's not mandatory.
right.
But if they want to participate.
So if like and I'm not like speaking for Communal Life or ICL, I always forget the order of the letters. But they have their respite set up, and they could continue to operate just like they are right now and never receive $1 from a managed care program and never receive a grant for the capacity building, and they could just keep operating as is. Or they could have the certification and have the option for that funding stream, or even the option for like some capacity building if they wanted to expand the beds that they currently have and do that. I got it right, basically?
Exactly. Yeah.
Okay. All right, good. Thanks for that clarification. Is the $50,000 grant per program, is that intended to cover all the startup costs mentioned, including hiring staff, making facility accommodations, legal services for contracting, establishing data sharing? Clearly, there are a lot of steps in setting up a program.
Yes, yeah, and that 50,000 is per program.
Okay, so there'll be 8 times $50,000 is what is going into this capacity building piece.
Yes, and then also the rate, which we're looking at, what current rates are / making sure that it's something that can help medical respites as they build their capacity.
Great. Would there be added steps if a patient has managed long-term care?
No.
Okay. We still have a few more minutes. If people have, I think I've hit most of the questions. If people have others. Just looking over to see if I can.
Sorry, Julie, there was just one follow-up question that I think we missed.
Okay.
Could a patient request approval from their own plan? Could they self-advocate for, I know we said that they would still need to be referred, but if by chance their hospital didn't know about it, but they did, could they request approval from their plan for a respite?
I don't see why not, as long as they're meeting the eligibility criteria and the managed care organization approves it.
So that raises an interesting question.
If
In
they're
my
in a
mind.
hospital, right, they're in the inpatient. And I think you were mentioning like the word of mouth, right? Like someone says, oh, there's a medical respite. They could request that from the hospital. And the hospital could request it from the managed care organization. I don't see why people wouldn't be able to inquire while they're in the hospital, meeting the criteria, not needing that hospital level of services if the hospital agrees with that. You know, that's interesting. Yeah, I'm not sure if the regulations cover that or not. It'll be interesting. You know, we'll have a public comment period with the regulations, so I'll send them to Bonnie and hopes that, you know, she can kind of distribute that and really looking for everybody's, you know, feedback and thoughts, and if something, you know, you think isn't going to work in the state or with the programs, you know, kind of flagging that for us. Or if you think it's perfect, let us know that too. But yeah, I think, you know, the public comment feedback is going to be really essential in fleshing out these little details.
I'm curious as I think about this and just try to envision the workflow and the referrals coming, the you know, potential self-referrals, provider referrals, managed care referrals. You know, when I think about Montefiore and Communal Life, which are the programs that I know all the years that they've been doing this, you know, one of the things that is so unique is that, as Deirdre explained, you know, the housing at risk program that she runs sort of is the gatekeeper and controls the flow to Communal Life. So they know who's there, they know when a bed is going to free up, they know, you know, it's just this flow that they're managing. So I guess in my mind, I'm like, if you build it, they will come. How is the, you know, it's going to be a relatively small pilot. How many beds are going to be in any one of these 8 pilots? And I guess I'm concerned about, you know, demand and supply.
Yeah, yeah. And you're right, there has to be a flow to it, and you don't want to overburden medical respite providers, and, you know, making sure that the proper channels are in place so that those who really need the medical respite beds are the ones getting it. This is also important.
Yeah, because like I say, I don't want to like, oh, you're approved, but there are no beds available.
Right.
And then you're still in the hospital waiting until a bed becomes available, by which time you could be, you know, the hospital could have found a discharge. Okay, a few more questions. Will longer-term home health aides be allowable in a medical respite setting?
Longer term home
So
health
I
aide.
guess like
oh, like if you have a home health aide on
if you have a
staff?
home health aide, could they come in and provide services to the medical respite?
Yes, that would be allowed. Yeah. Because you can either do the provision yourself or arrange for the provision.
In terms of the process over the next few months, how much feedback is a Department of Health willing to receive and make changes as appropriate?
Yeah, that's what that public comment period is for under the regulations. So, you know,
so that's the place to provide
that'll
the feedback.
be open for the 45 days. Yep, that's the time for the feedback. Yeah.
Okay. And
can I ask a quick follow-up to that, Emily? Will is that only for the regulations or for the pilot itself as outlined? Like, is there any opportunity to comment on that?
Yeah, so the pilot piece is really the partnership between the Medicaid managed care organizations, having a per diem, and then also, you know, those connections to the hospital. And then the regulations are the piece of, you know, the certification and the standards of the medical respites.
Do you have a sense of how many people or beds the pilot will cover based on the funding available and the per diem rate? So I guess that would be like practical terms. If one program is really good and they are, you know, their population, they're able to have a 30-day average length of stay. So as opposed to a 60-day length of stay, you're going to put through more people. So is there any caps on the funding?
No, you know, I think it's important to remember we're not trying to change what currently is in place. We're not trying to, you know, change the contracts or, you know, how medical respites or social respites operate. We're just trying to create an additional payment mechanism for expansion and capacity. So anything that is, you know, existing as far as, you know, capacity, we want to be able to provide, you know, additional dollars for the certification capacity, and then hoping to have a rate that is, you know, obviously enhanced to also help with capacity. But, you know, we're not trying to like recreate any wheels or undo anything that's already been set by the state. I mean, by the medical respite providers in their current contracts.
Can current OMH funded respite programs also apply to provide medical respite?
If you have new beds that you would consider to be a medical respite,
Okay.
And they meet the physical standards of the medical respite.
Can we decide to keep patients for longer than 90 days if they are close to housing? How would this work with the managed care?
Again, that's between the medical respite provider and the managed care organization.
And I think I saw this question this morning, and it's again now. Does anyone, you may know, maybe someone else knows, what is the total number of medical respite beds in New York City and upstate as of today, or the closest estimate? I mean, I think this morning we heard 68 at one place and 51. We can sort of, maybe, I don't know if New York City is around 140, 50.
Communal Life has 68, and then I'm looking back at the presentation from this morning. I thought ICL had like around 26, so maybe around 100, but I don't know if I'm missing some. I don't know if we have anyone from those programs who could.
Yes, ICL have 26 beds.
Okay. So
And
just
then
over
there's an upstate program too, I think, but it's I think it's only 10 or so beds. Or no, I'm sorry, 15 beds. Albany.
Okay.
So about
And
100.
there's actually one in Western New York as well, but I'm not sure how many beds they have.
There's a Boston model for payment. Have you explored that?
I'm not sure off the top of my head.
Okay.
If someone wants to send, I have my email at the end of that PowerPoint presentation that's going out, that sdh@health.ny.gov. So feel free to shoot me any emails. And Martina Hazi is the program manager, and she does an amazing job with this medical respite provider. I have to give her props. She's on the phone.
And of the 100+ beds that we just talked about, do we have a sense if those beds are usually always full, and if there's a wait list for those beds?
Ingrid, do you mind jumping in, at least for ICL's vacancy rates, or if you have a wait list?
Overall ICL vacancy rate has been anywhere between 85% to 100% since we opened. There are times when we are full at capacity, and we cannot accept individuals. But yes, pretty much the beds are pretty kept filled.
And I don't know if we have anyone from the Communal Life program on.
Hi, it's Marissa Greason from Communal Life. Yes, we have 68 beds within our respite program, and our capacity, we are pretty much 60 to about 60% occupied. So we have beds and don't always have, a wait list.
Well, this has been such a rich discussion. I thank you, Emily. Your breadth of knowledge is incredible. You've definitely been living with this for some time now. You really own the topic and the area. I think the whole group is probably looking forward to seeing the regulations later this month or in beginning of May. And I think there's, we've already seen in the discussion today areas for potential comment. And I think that as a group, we can work through comments. It seems as though you'll get lots of comments, and that's part of the process. So we look forward to that opportunity. I'm just looking one last question. The per diem rate is only paid if the patient is there, as opposed to the hospital sort of contracting and paying for the bed.
Right. The per diems for when the individual is it's for a service rate for the individual.
Right.
Yeah.
It's attached to the person. Okay. Well, Bonnie, any other questions before we go?
There was one question. I don't think that we got to it from John. Have you spoken with the PHNP organization about managed care, Dr. Cohen specifically? I don't know who that is. Maybe I don't know.
If that was the one I wasn't quite sure, but if you want to send something along, please feel free.
Yeah, John, why don't you plan to follow up with Emily about that? And there was a question in the chat in terms of referrals from the community for the Communal Life vacancies, but as it stands now, those vacancies can only be filled by a hospital or health plan that are paying for the beds. I don't, that's a question. So so just I think like tomorrow we're going to be getting into a lot more of these topics, but definitely something for an organization that's considering starting a respite program, that it may need to be a mix of this Medicaid pilot along with direct contracts, because there is, I know Mike Earhart from Canva is on our planning committee, and that's a difficult situation to be in, to have to pay rent, secure beds, secure staff, and all that investment, and then not knowing if you have a vacancy rate of 40%, as maybe has it sometimes, you're not getting paid, but your expenses exist, whether or not those beds are filled for the most part. So it may be the contracts with the hospitals and plans help to secure that bed and provide reliable income to the program. So I think
and that's where I think, going back to the first question, the education of the healthcare staff at the hospitals. We do a lot of education around social determinants of health that have legal issues, but we know we don't touch everybody, because these hospitals are huge and have huge staff and high turnover. So how does medical respite become sort of a normal specialty post-discharge consideration, so that it's not just the ones who were at the training on that day who know about it or who hear about it. I'm shocked might be strong, but I'm close to shocked that there are vacancies in any of the programs, because it seems like there definitely may be the patients in the hospitals. So
yeah, and I want to stress that existing contracts between managed care organizations and medical respites if, you know, the contract works out that beds are paid for, you know, when someone's not in it, this pilot would not undo that. It would just allow for payment from the plan side, right, when someone is in the bed. So again, this pilot was really, we're trying to be flexible, and we're trying to build alongside of the current infrastructure, not build over it. So it's going to be flexible. You'll see the regulations are very light. We're going to have guidance that we can, you know, kind of change as we get feedback from individuals. But you know, our intention is not to build new roads.
Well, thank you. We are at time. Thank you so much, Emily, and thank you, Julie. There's a lot to get through. The consortium is going to continue. I know the regulations aren't out as we'd hope they would be, but we will organize a follow-up to share that information with all of you and to start collecting some feedback for public comment. So please, we'll be in touch about that.